Here we present our patient, our abstract named Spherocytosis and Fulminant liver failure as main symptoms in the first Latin American patient with ATP6AP1 CDG. Pathogenic variants in the ATP1 gene have been only recently described as cause of this of a rare type of X-linked CDG. In 2016, 11 male patients were reported with immunodeficiency, hepatic and neurological disease to the X-linked ATP6AP1 deficiency. Since then, the phenotype associated with this disease has been expanded, with cases presenting with cutis laxa, aplasia cutis, sensorineural hearing loss, and proteinuria. Some of those patients can have even perinatal presentations, as you can see here. Intrauterine growth restriction, failure to strive, hypotonia, growth and neurodevelopmental arrest, respiratory complications, and shortened lifespan are findings in most of the patients with this rare form of CDG. Additionally, all described patients have presented with microcephaly, skeletal abnormalities, and intestinal findings. Immunodeficiency and severe liver disease also are prominent features of this disorder. And this is one of our patients affected. A male patient 4 months born to health and non-consanguineous parents after an eventful pregnancy was referred for evaluation of progressive jaundice and diarrhea. Since 2 months of life, he presented with cholestasis and anemia, starting investigation with child hepatologist. With the worsening of anemia and developing failure to strive, he was admitted to a hospital for further investigation and clinical management. On laboratory tests, the infant had elevated ALT, AST, and conjugate hyperbilirubinemia. Following severe hemoglobin decrease, he started to receive daily blood transfusion and was seen by hematology and found to have prolonged PTT, low fibrogen, low gluten factors 2, 7, 9, and likely secondary to the primary liver pathology. Bone marrow aspirate did not show signs of parasites nor hemophagocytosis. Nevertheless, Bloom's marrow was combined with abundant spherocytes. Comprehensive metabolic testing for other metabolic disorders, including transferrin isolatase vacuum, was normal. Reduced amounts of antibodies after BCG vaccination pointed towards immunodeficiency, but no immunoglobulins measurement was undertaken since patient clinical condition deteriorated very fast. He had some findings in skin, but he was not considered dysmorphic, as you can tell. Whole exome sequencing was performed to isolate clinical diagnosis, and a pathogenic mutation was found in ATP6AP1 gene. An increasing number of defects have been identified in different subunits of the ATPase5 in humans, as mutation of the ATP6B03 carrying malignant osteopetrosis, or ATP6B1B1 mutations in autosomal recessive renal tuberculosis. Furthermore, mutations in the ATP6AP2 gene were already associated with an X-linked intellectual disability, epilepsy, and Parkinson's syndrome linked to CDG. And recently, we have found pathogenic variants in the ATP6AP1 gene as an accessory protein of the mammalian vascular ATPase, were shown to cause general N-glycosylation deficiency, although not always you can pick up this alteration in the IF transferrin. This rare type of CDG, also known as X-linked immunodeficiency of type 47, should be included in the differential of liver failure in infants and toddlers, even in the absence of clinical features of immunodeficiency. The finding of spherocytosis in our patient expands even further its clinical phenotype, suggesting that the gene should be added to the diagnostic workup of patients with suspicion of hereditary spherocytosis, even if when they don't have specific skin findings or specific dysmorphic features. And we need to pay attention that even the usual test for CDG can be normal in a subset of patients with this rare X-linked disorder. Thank you very much.